Hello and good afternoon, everybody. Thank you for keeping us till the third and last day of the GAID Annual Congress. It's always said that desserts are left to the end. And in the end of this Congress, we are presenting a special session about two fascinating fields in endocrinology, namely osteoporosis and menopause. So this symposium is consisting of 4 lectures that will be delivered to you by experts in the field and eminent speakers. And at the end, you can keep your question and answers in the Q&A box, and they will be addressed to the speakers at the last session, which will be for discussion. I'm also honored to tell you that this session will be chaired by Dr. Faryal Saber, a consultant endocrinologist from Bahrain. And I will be co-chairing with her, Dr. Nadia Al-Ali, consultant endocrinologist from Kuwait and president of the Kuwait Osteoporosis Society. The first lecture of this symposium will be delivered by Dr. Riyad Suleimani, who is a professor of medicine and consultant endocrinologist from King Saud University in Riyadh, Saudi Arabia. He has obtained his medical degree in 1977, and 7 years later, he obtained the American Board of Internal Medicine degree. Later, he had become a fellow of the Royal College of Physicians and Surgeons in Canada, and he holds a certificate of special competence in endocrinology from the same place. Currently, Professor Suleimani is the president of the Saudi Osteoporosis Society and the past president of the Pan-Arab Osteoporosis Society, and he used to be also a past member of the IOF, the International Osteoporosis Foundation. There are more than 80 publications by Dr. Suleimani in the special scientific and academic interests he has, which are thyroid, osteoporosis, and diabetes. So without any further delay, I would like to welcome Dr. Suleimani to present the first lecture, which will be metabolic renal bone disorders. Please, Dr. Suleimani, the screen is yours.
Assalamu alaikum, bismillah ar-Rahman ar-Rahim. Thank you very much for the introduction. My topic will be on renal bone disorders. And this is a very important topic, not only for nephrologists, but for people who are interested in metabolic bone disease. But as you can imagine, it's a very complex topic, and it's extremely difficult to cover in 20 or 25 minutes. So I'm going to concentrate mainly on the clinical aspects of the disease, the recognition, and the management. Now, as we all do, we are going to start by outlining the presentation, the definition of renal bone disorders, its pathogenesis, its types, management, and hopefully at the end take home messages that are useful for us in our clinical practice. Metabolic bone disorders are really an important and frequent complications of chronic kidney disease, and they have abnormalities in bone and mineral metabolism. And the purpose of these adaptive mechanisms is to maintain the calcium and phosphorus homeostasis. But during all of these pathways, derangements happen in different areas in bone and vasculature, and that's what makes metabolic bone disorder a very important aspect of managing patients with chronic kidney disease. We in medical school have been told the term renal osteodystrophy to describe these changes that happen in bone in patients with chronic kidney disease. Nowadays, the term renal osteodystrophy is exclusively used to describe the histopathological changes that occur in bone in patients with chronic kidney disease. Now, the clinical and biochemical aspects and all of the other aspects now are made under the title CKD, mineral and bone disorder. And this is really the new name, which describes more specifically the mineral and calcific vascular abnormalities which occur in these patients. So a combination of the following abnormalities is what we commonly see in these people with renal bone disorders. Basically, abnormalities in calcium, phosphorus, parathyroid hormone, or vitamin D metabolism, changes in bone turnover, mineralization of bone matrix, volume linear growth or strength, and extraskeletal calcification. Now, before we go further, this is the important classification or nomenclature that was produced by Kedigo to describe the different stages, if you like, of chronic kidney disease, starting from G1, which is the normal kidney function with normal GFR, to G5, in which we are talking about very low GFR rates below 15 or 10 milliliter per minute. And this is, of course, the stage when people start talking about dialysis. So I think it is important when you deal with somebody with chronic kidney disease, you would like to know at what stage or at what category your patient belongs. So I think this is very important to have this information from the very beginning when you deal with these individuals. Now, these are the key players in this renal bone disease: the phosphate, the calcium, the fibroblast growth factor 23, the calcitriol, and of course the parathyroid hormone. Now, hyperphosphatemia and phosphate retention occurs quite early in the disease, and it is generally believed to be a very important initial trigger of bone disorder. And it occurs because of a decline in the GFR with a reduced filter phosphate load. And the phosphate retention promotes hyperparathyroidism by inducing hypocalcemia, by decreasing the 125 dihydroxyvitamin D3, which is in part due to an increase in the formation of F23, and by inducing PTH gene expression. So hyperphosphatemia, which occurs early, is bad for bone. And as I said, it's an initial trigger of bone disease in these individuals. And indeed, in animal models with uremia, when animals were fed a high phosphorus diet, as you can see, there is an increase in the weight due to the increased hyperplasia of the parathyroid gland in these animal rats with uremia who have been fed a high phosphorus diet. Whereas if you compare these animals with the animals who were fed low phosphorus diet, you can see that there is a stability of the hyperplasia of the parathyroid gland. So one of the, of course, techniques that nephrologists use all the time is to reduce dietary phosphorus intake and to use materials to increase parathyroid hormone production. And indeed, as the plasma calcitriol falls below even 60 milliliter per minute, you get an increase in the FGF23, and also later by functioning renal, there is a reduction in the 125 dihydroxyvitamin D3. This, of course, will cause decreased calcium intestinal absorption. It will cause calcium release from bone is being reduced as well, and there is a direct reduction in the number of vitamin D receptors. There is also good evidence that there is decreased responsiveness to calcitriol in these individuals. Hypocalcemia, of course, is a very natural occurrence in patients with chronic kidney disease. And this is related to hyperphosphatemia, the low calcitriol, and the PTH resistance. Now, the hypocalcemia in these individuals is sensed by the calcium receptors, the calcium synthesis receptor, and hypocalcemia, as you all know, is a very important, potent stimulus for parathyroid hormone production. There is also good evidence that there is skeletal resistance to parathyroid hormone in these individuals. So really, to wrap up what we have been saying in the last 10 minutes, the basic abnormalities which cause secondary hyperparathyroidism in patients with CKD include the following: phosphate retention, decreased production of calcitriol, hypocalcemia, increased production of FGF23, and reduced expression of all of these important receptors, and skeletal resistance to the action of parathyroid hormone. All of these will contribute to the occurrence of secondary and even later tertiary hyperparathyroidism in these individuals. And this really figure also summarizes what we have been saying in the last 10-11 minutes. Now, in terms of parathyroid hormone, if you were to look at the spectrum of renal osteodystrophy, you can see that there are two important extremes here. The first one is the high turnover bone disease, which is related to increased bone turnover, which manifests clinically and radiologically by osteitis fibrosa. And on the other hand, you have a low bone turnover, which manifests with two important clinical presentations, namely adynamic bone disease and osteomalacia. And the level of the parathyroid hormone might give you a clue to what is going on in the patient's bones. And you can see here that in peritoneal dialysis, for example, you see more cases of adynamic bone disease as compared to hemodialysis. So there are some important factors that contribute to the type of renal osteodystrophy that we see in these individuals. Now, as I said, the low bone turnover metabolic bone disease manifests with either osteomalacia or adynamic bone disease. It is commonly observed in diabetic patients who are on dialysis. And here you have a low rate of bone formation. The most common form of renal osteodystrophy, which is being seen nowadays, particularly in elderly diabetic patients, is this form. And here you really have an oversuppression of parathyroid hormone, which may be related to excessive use of calcitriol in these individuals. Now, these are very important laboratory markers that might give you a clue that you are dealing with this entity. The parathyroid hormone levels tend to be low. The alkaline phosphatase, or perhaps more importantly, the bone-specific alkaline phosphatase is low. Many people feel that this is a very important parameter, the bone-specific alkaline phosphatase. If you see a patient with high bone alkaline phosphatase, it is very unlikely that you are dealing with a patient with adynamic bone disease. So I think this is very useful. Unfortunately, it is not done routinely in hospital labs. Also, these people have a notorious tendency to develop hypercalcemia, even with smaller doses of calcium carbonate. Adynamic bone disease is make bone also susceptible to fragility fractures. Osteomalacia is related to reduced bone mineralization, and it is a form of low bone turnover disease. The high bone turnover disease is really related to a very active and a high turnover in these individuals, which is basically the result of hyperparathyroidism with the formation of the osteitis fibrosa, which is classically seen in bones. And if you were to do the histopathology, you will find the fibrous tissue intermingled with the rest of the bone structures. Now, over the years, there has been a change in the trend of the type of renal osteodystrophy that we see in people with CKD. You can see here that adynamic bone disease over the years seems to take the upper hand. And I think this is related to the overzealous use of calcitriol and calcium supplements in these individuals, particularly elderly diabetic patients. So really, in summary, if you have an undersuppression of parathyroid hormone, you get a high turnover bone disease. And if you have oversuppression, you get the low turnover bone disease. The clinical presentation of renal bone disease is interesting in that many patients may not seem to be symptomatic. And when they develop symptoms, they may not be very specific. And they might be in the form of bony aches and pains. And of course, we see this more particularly in patients with hyperparathyroidism, the proximal muscle weakness, especially with vitamin D deficiency, and the predisposition to fractures extraskeletal calcification, blood vessel calcification, and of course, in these individuals, there is an increased all-cause CVS mortality. Mortality is increased in these individuals, especially if they start to develop extraskeletal calcification and blood vessel calcification. The bone disease in CKD is more classically seen in patients on dialysis, but also seen in the majority of patients with stages 3 to 5. In dialysis patients, if they're 40, there is a relative risk of hip fracture, which is 80-fold that of age and 6 MASH controls, whereas patients with stage 4, for example, CKD, they have 4-fold higher risk of hip fractures than the general population. So these are some important statistics about fragility fractures in CKD. And as you can see, when you compare people with a relatively low eGFR compared to GFRs of 60 or so, you can see that there is a 5 times higher risk of fracture in these individuals. The incidence of hip fracture is also increased. The hip fracture related mortality is also increased when you compare people with lower eGFR, for example, below 45 milliliter per minute. Can we assess the bone disease in these people or not? DEXA scan, of course, is the tool that we use all the time to measure bone mineral density. And if a patient has got an eGFR of 60 milliliter per minute, and the bone mineral density is equal or less than minus 2.5, or there is a fragility fracture, here it's important to distinguish this osteoporosis as based on the T-score from, for example, a postmenopausal osteoporosis. In postmenopausal osteoporosis, for example, the alkaline phosphatase tends to be normal. The parathyroid hormone tends to be normal, which is not usually the case in patients with mineral and bone disease. Can you use DEXA scan for people with eGFR above 30? It is possible to use DEXA scan in these individuals. If the GFR is very low, it may be obtained in selected patients, especially those who have fragility fracture and no evidence of CKD MBD, i.e. They have normal PTH, normal calcium, normal phosphorus, and alkaline phosphatase. So this is really the new KDIGO recommendation that the DEXA scan to assess fracture risk. It can be used in people from G1, G2, and in G3 to G5 if you think that the BMD is going to help you to make a decision about treatment. The DEXA scan, of course, as we all know, has limitations, but the two most important limitations, as we know, are the following. DEXA scan will give you an idea about the quantity of bone in gram per centimeter square, not the bone quality, not the microarchitecture. And this, by the way, applies to CKD and non-CKD patients. Now, the second limitation of DEXA scan is that it does not correlate with bone histometry. I.e. it does not give you a discrimination about the exact type of bone disease, whether it's normal, high, or low bone turnover bone disease. And therefore, that will make life difficult for you to reach to a clear-cut therapeutic decision. Now, this is a very important slide. I think this is perhaps the most important slide in the presentation. Here you can see that all of these patients seem to have the same bone mineral density of 0.75 gram per centimeter square. But this patient is osteoporotic, this patient has osteomalacia, this patient has dynamic bone disease, and this patient has secondary hyperparathyroidism. So by bone mineral density, they all seem to have the same bone mineral density. However, as you can see, the pathology here is different in these different individuals. So not all that shines is really gold. And therefore, when you look at the bone mineral density, you have to take it in the context of the clinical and the radiological and laboratory findings in these people. Can we use FRAX? Yes, it is possible to use FRAX. As we know, it's the tool that we use to know the 10-year probability of a hip fracture or a major fragility fracture. And in this study, it was possible for the FRAX, whether with or without BMD, to predict major osteoporotic fractures in people with lower CKD. Bone biopsy is used in these indications. It is not done routinely except in specialized clinics. And really, this transiliac bone biopsy tool is used whenever you don't have a very good idea of what type of bone disease is going on, or if you have unexplained fractures, or you have refractory hypercalcemia, or suspicion of osteomalacia, or an atypical response to standard treatments for elevated PTH, or a progressive decrease in BMD. However, it's invasive and requires special equipment, and it cannot predict the fracture risk at all. How do we treat renal bone disease? These are the new KDIGO guidelines. If the patient is in stage G1 or G2 with osteoporosis or high risk of fracture, the management here is recommended as for the general population. So we have no problem with this category of patients. Now, in patients with CKD, G3A to G3B, and if the PTH is in the normal range, again, the treatment recommendation are used as for the general population. We use the same WHO criteria to diagnose osteoporosis and to treat osteoporosis in these individuals. Now, this is the group that give us difficulties all the time. And these are the people who have good biochemical abnormalities of CKD MBD. When I say biochemical abnormalities, I mean they have high phosphorus, high PTH, and so on. And quite often, it may be necessary to do a bone biopsy in these people if you really would like to know whether there is room for treatment in these people or not. If the patient has a history of fragility fracture without evidence of renal osteodystrophy, the patient is a candidate for osteoporosis treatment. If the GFR is between 15 and 30, with fragility fracture and without evidence of renal osteodystrophy, the pharmacologic therapy for osteoporosis may be indicated. If the estimated GFR is more than 30 and there is no evidence of CKD MBD, these people can be treated with bisphosphonates as patients without CKD. In lower GFR rates, let us say below 30 or so, most people will say that bisphosphonates are generally not recommended, and here you might need to consider denosumab. But watch for hypocalcemia whenever you use denosumab in these individuals. So patients with evidence of CKD-MD, and especially if the GFR is very low, generally speaking, the anti-resorptive osteoporosis drugs should not be administered in these people. You can concentrate on controlling secondary and tertiary hyperparathyroidism. You prevent over suppression of parathyroid hormone, and you treat the acidosis and vitamin D deficiency. So this is really a summary of how you manage these people. You have to find out the stage of the renal disease in these individuals, and depending on the presence or absence of biochemical abnormalities of CKD, MBD, namely hyperphosphatemia and PTH, you can make your decisions about the treatment. So really the management goals here is to intervene early, and you monitor all these important players that are playing different roles in renal bone disorders, mainly calcium, phosphorus, parathyroid hormone, and vitamin D. You try to maintain calcium, phosphorus, and 25 hydroxyvitamin D levels as normal as possible. You prevent and treat hyperparathyroidism by dietary phosphate restriction, phosphate binders, calcium supplementation, and in patients with advanced CKD and hypercalcemia, PTH is very high. you may need to consider the use of calcium mimetic, but watch for hypocalcemia and watch for oversuppression of bone. So these are two important issues that need to be considered whenever you use calcium mimetics. And I think it won't hurt to have the cooperation and opinion of our colleague nephrologist in these individuals. So in conclusion, and these are the take-home message or messages, if you like, the first thing that we would like to emphasize here is that these disorders are commonly seen. The fragility fractures are increased in these individuals, and it may be related to high or low bone turnover disease. You can assess the bone integrity by doing a DEXA scan, and you can utilize the FRAX in these individuals. And in the absence of biochemical abnormalities, you can treat the osteoporosis as in the general population. It is only tricky when you have abnormalities in the biochemical parameters that you really have to judge the treatment indication as it is related to possible reversibility or progression of the disease. I think before starting the treatment, it is important to know the stage of renal impairment and the type of bone turnover in your patient as much as you can. And you can utilize the lab tests, most importantly, the parathyroid hormone, the alkaline phosphatase. And I think, generally speaking, particularly in these individuals, I think you have to know the trend of the changes that occur in these individuals, not the lab findings in one day. You have to see whether the changes are persistent, they are improving, they are deteriorating, is the calcium rising or is it going down, and so on. Consider bone biopsy if the situation is not very clear. So with that, I would like to thank you for listening to this presentation, and I thank the moderators as well. Wassalamu alaikum wa rahmatullahi wa barakatuh.
Thank you, Dr. Riyad, for this very interesting subject. And now we would like to introduce Professor B. Hughes, who gave a lecture earlier today. And Dr. Astalahi introduced her, but Dr. B. Hughes has graduated from Tufts University, and she trained at Tufts. And she's an endocrine fellowship at Harvard. She led researches in the Bone Metabolism Laboratory at the USDA, Human Nutrition Research Center on Aging, and is a professor of medicine at Tufts. She has a lot of researches, more than 425, and book chapters, as well as reviews, peer-reviewed journal articles. Please, Professor Hughes, all the floor is yours. Thank you.
Hello, it's nice to be back. And we're going to address the topic of correcting vitamin D deficiency and some of the do's and don'ts related to that. This follows on from the presentation I gave earlier today. Again, my disclosures. And so that we're all using the same language here, I'd like to just indicate to you that when I'm talking about deficient vitamin D, I mean a 25-hydroxy-D level under 12 nanograms per mil, inadequate or insufficient 12 to 20, and sufficient is 20 and higher. These are the definitions derived by the Institute of Medicine, which has in the last year been renamed to the National Academy of Medicine, NAM. We're going to look, we know that vitamin D in food sources is limited, sun exposure is important, and we know that supplements are often required. So let's focus on several aspects of to consider when supplementing. We need to access the need, determine the dose, decide on the dose frequency, and when to take a supplement during the day, specifically in relation to meals. So in terms of need, I don't think you need to be convinced that insufficiency and deficiency are rather common in the Middle East. This was a survey led by El-Haj Foulahan of evidence showing the levels color-coded by range. And so much, and the white areas, the ones where there were no data, doesn't mean they were not low. It just couldn't be documented. So this applies to both adults on the left and children on the right. So now let's go to the business of looking at the dose, but we're going to come at it a little indirectly. I'm going to focus on doses and the evidence related to bone health, fractures, and so forth. So I think a very high quality meta-analysis by Yao, published in 2019, looked at the effect of a large number of trials on fracture risk. And in this particular picture, we are looking at trials that use supplementation with vitamin D alone. The upper panel shows findings for any fracture, and that was not significant. It was leaning toward favoring control of the placebo group. And hip fractures, same thing, not significant, but almost demonstrating more falls with D-supplementation. The other aspect of this same meta-analysis was to look at the trials that used vitamin D plus calcium and their effect on any fracture and hip fractures. Upper panel, we see that these trials, let's see, 6 of them that were identified that reported any fracture showed a risk reduction of 6%, significant in fractures. Hip fracture risk reduction was 16% and quite significant in the combination treatment. So if this is where we need to be, let's just focus next on the vitamin D levels used in these calcium and D trials to see if we can address what dose we have evidence for being beneficial. And if you look, highlighted in the green rectangle, that all of these trials except one used 800 units a day. And the trial that used a different dose was the Women's Health Initiative using 400 units a day, which we've seen is probably not that effective. But overall, the evidence for lower fracture risk resides in 800 units a day. And the trials that combined with calcium were the older trials, and they did not test higher doses. And they didn't test D alone. So I think that gives us solid footing for recommending 800 units of vitamin D together with adequate calcium intake. Some individuals will need more, those with osteoporosis, no sun exposure, fat malabsorption, and conditions that you're familiar with. It's useful, should you need to go to higher doses, to have an idea of what dose to recommend. And so here are average increments in 25-hydroxy-D for given increases in D dosage. If you add 1 microgram, 40 units, you get a 1 nanomole per liter increase in the circulating level. If you add 100 units, you get about a nanogram. That's a rule of thumb. It applies generally, but not specifically to individual patients, but it's a good starting point. In dealing with people with very high BMI, you know you're going to need a bigger dose because they'll have a lower starting level. And Van Groningen gave us a nice formula that is shown here that you can use to make an estimate that is a weight-based estimate for the dose needed in these individual patients. We know that color of skin, the amount of melanin in skin will influence the amount of skin synthesis of vitamin D. And the darker the skin, the more it absorbs the ultraviolet B rays of the sun that would, if they weren't absorbed by melanin, would promote vitamin D production. So I took this picture from data in a book by Mike Hollick, who did a lot of the sunbox or artificial experiments. And this one was actually done in these two locations, Boston at 40 degrees north latitude and Miami, which is 26 degrees north. I'd like to point out that the latitude of Dubai is 25, very close to that of Miami. So you could use that as an approximation of what you get. So with the lightest skin, or even you don't make D at our latitude in the winter. The angle of the sun is so wide that these rays needed don't reach Earth's surface. But in June and August, with the lightest skin in Boston, you would need 2 to 8 minutes. With the darker skin, you need much more than 10 times longer exposure to get adequate production. And in Miami, which is most relevant to you, in the light-skinned people will need 10 to 15 minutes in the winter and 1 to 5 minutes in the summer. And need longer in the winter, but they can still produce D. And we're talking about time of day around the middle of the day. The further you get out from the middle of the day, the fewer of these rays will actually reach the surface of Earth. And we're talking about minutes with hands, face, and arms exposed. This gives you a general idea. Many people wear sunscreens which completely block, if they're high number sunscreens, they will block the UVB rays entirely. The question comes up, is it D2 or D3? Does it matter? And the answer is no, it does not matter. You would need a little more D2 because you don't achieve quite as high a level with D2 as you do with the same dose of D3, but that's an easy adjustment to make. So whatever is available and meets general clinical practice quality standards is fine. Now we get to an interesting issue, and this is where some of the newer points come into play. You know the classic picture here. You can give the same ultimate cumulative dose on a daily, weekly, or monthly basis and achieve similar levels of 25-hydroxy-D. At the infrequent or less frequent monthly dosing, you get a more variability shown by those little circles and squares and stars above. But the mean will be fairly similar. And this has encouraged people to recommend doses on a monthly or even less frequent basis because on the premise that compliance would be better and that the patients or would like it and prefer that. But now here's the rub. The question is, do these high doses, which we know raise 25-hydroxy-D levels, result in greater amounts of the active metabolite 1,25-dihydroxy-D. Let's take a look at a meta-analysis of 23 randomized controlled trials that looked at the effect of vitamin D supplementation on circulating FGF23 levels. And in the upper, the red rectangle, we will see that if you're giving activated forms of D, you get a very high big increase in FGF23. If you give doses over 2,000 units daily in 13 trials, they found higher levels of FGF23 than was seen in supplementation with lower doses of D. And that was a P for interaction there that was highly significant. So these big infrequent doses are going to trigger the release of FGF23 from bone. Now, is that good news or bad news? Well, in an elegant study in mice, FGF downregulates 1-alpha hydroxylase and upregulates 24 hydroxylase. So basically, the premise here is that high doses of D, daily or boluses, may not lead to the higher 125, the active 125D levels. So if we follow the little picture here, we start with high dose D increases FGF23 coming from bone. Look at the little red arrow on the kidney, and it's blocking the 1-alpha hydroxylase to produce the active compound. Not only that, it's increasing, shown by the green arrow, the lower green arrow, it's increasing the metabolism of the current 125 to the inactive metabolite. So it is basically having the net effect, high doses have the net effect of increasing the circulating 25-hydroxy-D, but lowering the circulating levels of the active compound. So what does this mean? It means that the elegant vitamin D endocrine system reads this infrequent or bolus or high dosing daily as a signal that of threat against toxicity. And so it steps into action and makes sure that the active metabolite is both less produced and more rapidly metabolized to 124.25, which is inactive. So we're measuring the wrong thing, in essence, when we are using these doses. So, and we know, here's another example, one of the earlies, that very high bolus dosing was causing more falls and fractures. As I showed you in my earlier presentation, weekly dosing or monthly dosing with 2,000 units per day equivalent, that is 60,000 units, was increasing falls. So we may be actually creating a vitamin D deficient situation with this aggressive dosing. And the last area I wanted to focus on is the question of, does it matter when during the day you take the vitamin D? And we're going to look at some absorption procedure. The classical procedure or method of measuring vitamin D absorption is shown here by Cliff Lowe, published in 1985. And it was carried out as follows. You would treat with, give people a single dose of 50,000 units of D3, and you would track their circulating 25-hydroxy-D levels, and their parent, actually it's the parent vitamin D levels that were achieved. And it was, you could see in the picture on the left, people with malabsorption, where the cases A, B, and C, and G, D, and E on the bottom flat line markers. The normals would achieve their peak level of parent vitamin D after consuming this big dose around 12 hours. And so that and it would decline thereafter. That became the standard of measurement. We, a few years ago, made a modification of the method that we think gives a more accurate reading. We would give an oral dose of D3, but that was spiked with deuterated D3. And we could assay by LC-MS baseline and follow up parent D levels and get the deuterated to undeuteраted ratio, so we could correct for problems that could take place over that 12-hour period when you're waiting for the peak level. Such things as individuals being exposed to sunlight during that time, or inadvertently taking vitamin D in a pill or in a food item or something that would distort the absorption. So once we put that method into application and looked at whether this fat-soluble vitamin D3, would be influenced by fasting conditions or non-fasting, and moreover, whether the amount of fat in the meal, since it's, the fat gives you the physiologic basis for absorbing D. D travels in the micelles up to the surface of the GI tract for absorption and so forth. And what we found that fasting was not good compared with a meal containing 10% fat. We then did this as second experiment, in which we wanted to look at a more typical amount of dietary fat. Use that as typical in the US, 30% of calories as fat in the meal. And we saw that if you took a typical meal with fat in it, you had 30% higher absorption of vitamin D than if you took D under fasting conditions or under conditions of a fat-free meal. So since most, unfortunately, meals in the US contain fat, we can just generalize that here to take it with a meal as opposed to in the fasting state. I would like to conclude with several observations here. Vitamin D supplementation in modest doses, when combined with an adequate calcium intake, lowers fracture risk in adults with insufficient and deficient 25-hydroxy-D levels. That's the crux of all of these trials. 800 units of D taken daily with adequate calcium is sufficient for the general population. Others, including those with malabsorption, osteoporosis, obesity, dark skin, may need more. As you know, the Endocrine Society recommends achieving a level of 30 nanograms per mil to be adequate. I could comment that the Endocrine Society has a new group of experts put together to review the Endocrine Society's guidelines, and I think we'll be hearing updated guidelines from them perhaps in the next year. The recent null mega trials do not alter the importance of vitamin D together with calcium in meeting these daily requirements, particularly in regions of widespread vitamin D insufficiency, such as the Middle East. High daily doses and bolus doses of vitamin D do not guarantee an adequate level of 125 dihydroxy D. Now, you may be asking, well, should we be measuring 125 in everyone? Absolutely not. Just avoid the high dosing and avoid the bolus dosing. And I think that will take care of this problem. And the safety of these high doses hasn't been, is in question, not in question anymore. It increases risk of falls in those at high risk. And the safety in younger adults is uncertain. But why use high daily dosing when we know that it is going to impair ultimately the achieved level of the active metabolite? So I just think high dosing and infrequent dosing should be out of the picture. And if you're recommending a daily supplement of 800 or so units of vitamin D, you can get much better absorption if you take it with a meal. So that's my take on the do's and don'ts at this point. It's a constantly changing picture. So we're trying to keep up with this massive amount of literature that we're seeing, and it is eternally interesting to follow. Thank you for your attention.
Thank you very much, Prof. And I'm thinking this was a very enlightening lecture and probably a practice-changing lecture. I'm sure it will be inviting a lot of questions at the end of the sessions. So let's move now to the third lecture in our symposium today, which is about the Gulf Osteoporosis Guidelines. And it will be presented by Dr. Yusuf Al-Saleh. One of the most active endocrinologists in the region is Dr. Yusuf Al-Saleh, who is currently an associate professor of medicine and endocrinology at the King Saud Abdulaziz University in Riyadh, Saudi Arabia. He obtained his RCB from London, UK in 1994. And 2 years later, he also obtained the Arab Board of Internal Medicine. He is then after that, he joined a fellowship program of endocrinology and diabetes in the University of California, San Diego, USA. And he obtained the fellowship in the 1998. On top of that, he also had a diploma of healthcare and hospital management from the American University of Cairo in June 2010. At some part of his career, he was in charge of all the residency program in the Kingdom of Saudi Arabia, as he was the president of the Scientific Council of Medicine. I still recall early in 2019 when Dr. Yusuf Al-Saleh called all the Osteoporosis Society in the GCC to have a meeting there in Riyadh and to come up with this guideline. So I'm glad that today it will be presented in our Congress. Dr. Yusuf, please.
Assalamu alaikum wa rahmatullah. It's my pleasure and honor to join you in the Gulf Association of Endocrinology and Diabetes Annual Virtual Congress 2021. And I hope everybody is enjoying the experience of our Congress and achieve academic progress. So my task is to talk about the diagnosis and management of osteoporosis in postmenopausal women in Gulf Cooperation Council countries. And this is a consensus report that I'm going to talk about in the following 25 minutes or so. These are my disclosures. And this is a small synopsis that a consensus platform is provided by the experts of the Gulf Cooperation Council countries, respective osteoporosis societies, in which specific guidelines can be developed further for regional use in the assessment and treatment of postmenopausal women at risk of fractures due to osteoporosis. This is a gathering that ended up with this, inshallah, beautiful and useful publication in a very well-respected journal, Archives of Osteoporosis, one of the journals of the International Osteoporosis Foundation, and this was published in 2020, actually to the second part of 2020, and titled Diagnosis and Management of Osteoporosis in Postmenopausal Women Gulf Cooperation Council Countries Consensus Statement of the GCC Countries Osteoporosis Societies under the auspices of the European Society for Clinical and Economic Aspects of Osteoporosis and Osteoarthritis, the SQ. We developed a task force that included at the chair of biomarkers of chronic diseases in King Saud University in Riyadh, Saudi Arabia, in cooperation or collaboration with the Saudi Osteoporosis Society, where regional experts from respected GCC osteoporosis societies were hosted, and we gathered together, including an advisor from the European Society for the Clinical and Economic Aspects of Osteoporosis and Osteoarthritis. The closed door assembly of experts commenced on February 15 and 16, 2019 in Riyadh, and every osteoporosis society in the Gulf region was represented by a representative. There was many presentations laid down by experts by the experts. So we divided the main topics of the consensus report between each member, and each member had to come and present his findings, his literature review on that specific aspect. We ended up with our medical writer writing a draft recommendation, and this went to almost a year of discussion, back and forth revisions, which reached more than 15 revisions till we end up with the publication in its final form. The diagnosis section says that made on the basis of T-score of bone mineral density as assessed through DEXA of femoral neck, spine, or distal radius. You have to have two sites. A value of less than minus 2.5 standard deviation is considered to be osteoporosis. Therapy is indicated if the risk of major osteoporotic fracture above what we are going to discuss later, upper intervention threshold, using a country-specific FRAX model or a surrogate model if that country has no specific model. If patient has a reading above an intervention threshold with known value of measured BMD, then that patient needs treatment. We stated that other diagnostic modalities like heel ultrasound can be used for screening. They lack standardization, and confirmatory DEXA for abnormal findings is needed. So whenever you do heel ultrasound for screening, if it's abnormal, you go for DEXA, but you cannot use it for diagnosis of osteoporosis. You can diagnose osteoporosis by the presence of low trauma fragility fracture, especially hip spine, but also distal radius and proximal humerus are considered as osteoporotic fractures. A question that we laid in the consensus report is BMD enough? BMD is expressed as a gradient of risk, relative risk per standard deviation decrease in bone mineral density, predicts an increased risk of fracture that is comparable across the population. But the absolute risk of hip fracture may vary by up to 20-fold between countries in the world. If you use BMD alone, it has suboptimal sensitivity and specificity, and the ability to predict fracture risk is improved when BMD is combined with clinical risk factor, and this is what came up with FRAX, the fracture risk assessment methodology that we use. These are the risk factors that are, when added to BMD, increase the prediction of fractures in people: age, the sex, low bone body mass index, history of fragility fracture, family history of hip fractures, history of chronic steroid use, the presence of rheumatoid arthritis, premature menopause less than 45 years. This is the definition. The presence of diabetes is not included right now in the FRAX, but it's planned to be in the future, and we have a way to compensate for the absence of diabetes in the FRAX scoring. current smoking, alcohol abuse, and incidental finding of height loss more than 4 centimeter and thoracic kyphosis. These are not mentioned in the FRAX, but in population studies, all of these correlate very well with the risk of fracture. The use of bone markers of formation is still not available widely in our countries. The serum collagen type 1N probeptide and resorption, the CTX, serum C-terminal cross-linking, telepeptide of type 1 collagen, have value in predicting fracture risk and follow-up of treatment response. Fracture risk assessment, country-specific model, as I mentioned, should be used. Currently, there are FRAX models for 5 countries in the Middle East. We recommend the use either of Kuwait or Abu Dhabi versions for GCC countries. We belong to the same ethnic background, and for countries in the region who do not have FRAX model, to use one of these two. Kuwait data looks robust with 3 years of data collection. The paper from Kuwait is between 2009-2012, and the collection was quite good. We have to understand the limitation of FRAX because there are certain things that are not included in the FRAX. One of the things is it depends on adequacy of epidemiological information. Limited countries models available in GCC, just Kuwait and Abu Dhabi, and does not accommodate all known risk factors. The false biochemical markers, quantitative ultrasound, and as we mentioned, diabetes is not there, and also lack details on some risk factors. So the dose response of steroid, it just says glucocorticoid use, yes or no, but it does not take into consideration the dose of steroid. We know that the higher the dose, the more is the risk of developing osteoporosis and fractures. Smoking also, the dose response of smoking. Those who smoke 2 or 3 packs is different from a couple of cigarettes a day. The number of fractures, so it says previous history of fracture, yes or no. But we know the more the presence of fractures in a certain person, the higher the risk. And that's not taken in consideration in the FRAX model that we have now. The model is most relevant for untreated patients and does not replace clinical judgment. Fracture risk assessment, FRAX can be calculated without DEXA at baseline. So as we're going to see in subsequent slides, you can use FRAX to even decide who are the patient that needs to have DEXA scanning. Low risk patient, when you do FRAX, if the patient is in the low risk category, should be followed with advice on lifestyle changes, while high risk patients should be treated. Patient in the intermediate risk, then you do BMD and you re-measure the FRAX. So treat those with high FRAX score based on the individual country's intervention threshold after you do the BMD for intermediate people. So the case finding study strategy has been adopted by NOF, the National Osteoporosis Foundation, and in their guidelines in 2008. So you look at clinical risk factors, and based on the clinical risk factors, you do the FRAX. So ask the questions, the 9 risk factors we talked about, and if the FRAX reading is high, you go ahead for treatment without a BMD. If it's low, follow up and advice on lifestyle changes and adequate calcium, vitamin D, sun exposure, avoidance of nutrients which increase bone loss. When the FRAX score is intermediate, then these are the patients that you go for bone mineral density. And then after you get your FRAX reading, you enter them in the FRAX module. So you do refrax, high risk treat, low risk follow up. Trabecular bone score, and this is what we mentioned in the consensus report, may serve as an additional information to BMD measurement and FRAX, so it helps in increasing the diagnostic accuracy of BMD and FRAX. FRAX reading should ideally take into consideration exposure to glucocorticoids, the data on lumbar spine, and this is a limitation of FRAX, so you have to use the neck of femur density, while we know that some patients have significant reduction in lumbar spine T-score rather than, or bone mineral content rather than the hip, and that's not included in the FRAX calculation. The use of trabecular bone score, hip axis length, fold history, immigration, and diabetes status are these are some of the limitations of FRAX and not included in the current score. We hope that with time it improves its points that it takes into consideration. Vertebral fracture assessment, VFA, should be done for all patients whenever possible, and this can be done on the DEXA scan machine by inserting a software that will tell you the VFA, and it measures or tells you the picture of the spine, shows those vertebrae with collapses, and the patient does not need to go for lateral spine X-ray. History of more than 4 centimeter height loss or kyphosis, recent or current long-term oral steroid therapy, or a BMD to score less than -2.5 are additional indications to do VFA. Therapy decision, this is adopted from the European consensus or European guidelines on osteoporosis published in 2019 by John Canis and his group, and characterization and treatment pathways of fracture risk by FRAX, major osteoporotic fracture probability. So you FRAX the patient and you put the score. If there is a patient lies in this red zone, this is very high risk patient and needs to be treated. The green zone, that he is safe, low risk, and does not need treatment. And the question is here in the orange area, these are the patient in the intermediate zone. And these are the people that you need to do BMD for them and refrax them. So within the orange zone, we need to decide the intervention threshold for giving these patient treatment. And when you do FRAX, look at this X signal. If the patient is below the intervention threshold, this is a low risk. This is after doing the BMD and refraxing the patient. So measure BMD. If it's in green, low risk, you don't do anything. If it's in the red, treat. If it's in the orange and above this intervention threshold line, then this is a high risk patient that needs treatment. So he's an intermediate risk group in the orange area, but he's above the intervention threshold. And for these people, they are not in the red threshold, which is clearly indicated for therapy. They are in the intermediate zone above the intervention threshold and need to be treated. If they are below the intervention threshold, then they do not need to be treated. So this is a simple explanation of this figure. This is again taken from Kuwait osteoporosis guidelines. This is the intervention threshold for patient in the orange, in the intermediate zone. So the upper assessment threshold is calculated by multiplying 1 by 2 times the intervention threshold. So this is the upper assessment here, this line, and this is the lower assessment threshold. Above in the red area, consider treatment, green, no treatment. In the intermediate zone, you do BMD and you refrax the patient. If they are above the intervention threshold for Kuwait, then you treat these people. If they are below, you don't treat them. We know that the annual incidence of hip fractures in women varies across countries. We lie here in the bottom of this curve. So Saudi Arabia and many other Gulf regions, Gulf countries or Middle East countries are here in this region. We are considered as low risk for fractures. And as you can see here in this green, Gulf countries in this area, the low. And these are the countries with an incidence less than 100 per 100,000 population. Now, once you get your FRAX model for your country, you have to try to set your intervention model. So there are 3 models that are available. So the fixed threshold model, this is used in the state, the National Osteoporosis Foundation, publication 2014 by Felicia Cosman. The 10-year probability of a fracture, so it's a fixed threshold. Once the patient is at or above this threshold, he needs treatment or she needs treatment. 10-year probability of a major osteoporotic fracture, more than 20%. 10-year probability of hip fracture, more than 3%. This is a fixed threshold readings, and the patient needs to be treated. While in Gulf countries, this is the curves for Kuwait, Abu Dhabi, and if you look at the 10-year probability of a major fracture in Kuwaitis, this is called a moving threshold. So the threshold goes higher with advancement in age. This is the age at the horizontal line, and this is the intervention threshold, low threshold at younger people, and higher threshold when people get elder. And this is to avoid over-treating elderly people with osteoporosis therapy. So this is called a moving threshold. This is a model seen here or shown here for some of Kuwaiti people. The third technique or third methodology is called as hybrid model. And this is again demonstrated in Kuwaitis. So this is the fixed threshold up to 70 years of age, and then the use of moving threshold according to age. The higher the age, the higher is the intervention threshold reading for 10-year probability of fractures. And this is what is recommended probably in our region, because we have low risk of fractures, especially in younger people, and to avoid over treating our population, then probably this is the best model to be used. Just a word about Saudi fracks. This is not mentioned in the consensus report, but to shed some light on this aspect, this is the curve for Kuwait, Abu Dhabi, and Saudi Arabia in blue. We are more or less similar to Kuwait and Abu Dhabi, and this is expected. Minor differences between us, especially with people above 60 years of age. The Saudi fracks is going to come very soon. So in Kuwait, age-based fracks intervention threshold were able to identify women with higher fracture probability versus fixed T-score thresholds, particularly among the elderly. This is the paper for Kuwaiti fracks, and this is Helena Johansson from WHO, the John Canis group, with our colleagues from Kuwait who are involved in the put of the fracks, Kuwait fracks. So this is again mentioned in the consensus report. Age-dependent fracks-based intervention threshold can be used in countries with moderate to high fracture risk, such as Oman and Kuwait, in identifying women with higher fracture risk. And in countries with low incidence, such as the Kingdom, the hybrid threshold use of both fixed and age-dependent may be more suitable, as it avoids patients with low risk for fracture and targets only high-risk elderly people. We put in the consensus report advices on lifestyle and dietary measures like calcium and vitamin D intakes, the advice for weight bearing. I want to remind you that we have these consensus reports also. This is the Saudi vitamin D consensus report published in 2017, and furthermore we published the GCC countries consensus summary statement on vitamin D diagnosis and management of vitamin D deficiency in the Gulf countries, and this is again published in 2020 by experts from the Gulf region. So please have a look on these, and it summarizes very nicely the method to diagnose and treat vitamin D deficiencies in our countries. We put in the consensus report for osteoporosis this graphic representation of many aspects of the consensus report, like diagnosis, fracture risk assessment, the advices on lifestyle. We adopted or modified this with permission from Professor Canis' statement or guidelines in 2019, the European guidelines, and we modified them to suit the GCC countries. So it's not exactly the European guidelines. It goes for figures related to GCC countries. We also included this pharmacological management table in which we describe various agents to treat osteoporosis and mentioning statement on each of these agents, when to use them, and this is the alternate first line therapy, and this is alternate therapy. So this is a nice table that we thought it's going to be very helpful for healthcare practitioners in their daily practice. We also included this table, which is again adapted from John Canis group, and this is mentioning the effect of various treatment available in the Gulf region on vertebral fractures and non-vertebral fractures collectively. So where is the agent? These agents work at these sites. Statement about anabolics. Teriparatide is preferentially recommended for patients at high risk of fracture, like those in the immediate post-fracture period and those with a fracture and extremely low bone mineral density. A statement on system of care. The utility of age-dependent fracture thresholds in population screening approach has been recently validated as feasible, effective, and health economically viable. So whenever possible, any postmenopausal women and elder men do fracks without doing a BMD and see where this patient lies low risk, advice on lifestyle, high risk, you can treat them, intermediate risk, you do beyond mineral density. And that is an excellent method to save our resources and selecting who are the patients that needs to have BMD. We recommend coordinator-based fracture liaison services to be developed in the region. Recently, in the Saudi Osteoporosis Society, we have combined meetings with the International Osteoporosis Foundation to set the FLS centers in the kingdom. We know that there are several centers in the GCC countries, but we are looking for more. We think that we are lagging behind from instituting this viable and extremely important service. The consensus report has been endorsed by the Saudi Osteoporosis Society, who kindly hosted the physical meeting in Riyadh in 2019. It is endorsed by Kuwait Osteoporosis Society, the American Association of Clinical Endocrinologists, the Gulf chapter, which is currently transferred to the Gulf Association of Endocrinology and Diabetes, for which this presentation is made for in its first annual virtual congress. So GATE is extension of Gulf American Association of Clinical Endocrinologists Gulf chapter. Emirates Osteoporosis Society, Emirates Diabetes Endocrine Society, Oman Medical Association, Bahrain Osteoporosis Society, and Qatar Osteoporosis Society. I would like to end my presentation by thanking our dear colleagues, Professor Nasser Daghri, the chair of the Center for Biomarker Research in King Saud University, the College of Science, and he is also the dean of that college. Sean Sabiko, who is our medical writer, Thamir Al-Isa from Kuwait, Samar Al-Imadi from Qatar, Fathiya Al-Awadi, and Mustafa Al-Azzi and Abdurrahim Al-Suhaili from Emirates, Jamila Mukhaymar from Bahrain, Abdullah Al-Fataisi from Oman, Salim Al-Qassabi, Abdullah Al-Fataisi and Salim Al-Qassabi, both from Oman, Professor Riyad Slimani, the president of the Saudi Osteoporosis Society, and Professor Jani Vrijnster from IOF SQ. All of them contributed equally to this paper. I'm very thankful for their great support, their excellent expert opinion, their patience on a person like me who made their life miserable during the preparation of this consensus report with hundreds of emails and communications through social media. But at the end, we came up with a beautiful paper that I call everybody to have a look on it and hope that it's going to be of great help to diagnose and treat our patients with osteopenia, osteoporosis. Thank you very much for your attention.
Thank you, Dr. Youssef, for this outstanding presentation as usual. And now it gives me a great pleasure to introduce one of my dear colleagues, Dr. Huda Azzuddin. Dr. Huda Azzuddin is a consultant in diabetes and endocrinology, director of Academic Affairs and Healthcare Center for Diabetes and Endocrinology in Abu Dhabi. Dr. Huda she's a fellow in the Royal College of Physicians from London and Edinburgh, as well as a fellow from the American College of Endocrinology. Dr. Huda has held several leading clinical and academic positions in public and private medical facilities in UAE, and has been actively involved in various scientific and professional committees, medical education, as well as review for regional peer-reviewed medical journals. Her main interest is in thyroidology, diabetes, and women's health. And today she's going to talk to us about postmenopausal syndromes update. Please, Dr. Huda.
Thank you very much, Dr. Frial, for the kind introduction. Thank you for the organizing committee to invite me to speak about menopause. I just wanted to inform you that this is a very difficult task to finish all aspects and updates on the matter in a 25 minutes. But I'll just allow me to skip through some of the slides or expand on some as necessary. I have no disclosures to make, but I really wanted to emphasize just the brief content of my presentation, starting from the knowledge and attitudes towards menopause, some diagnostic and assessment tips, and then I'll go through the management guidelines and end by recommendations. Over the past decades, the investigators in general have showed a great interest in publishing knowledge, attitudes, and practices in various health conditions, and menopause is no exception. So basically, from looking at surveying women's attitudes and knowledge as patients or as major public health issues, to healthcare providers' knowledge, attitudes, and practices, and also involving the policymakers, which is really outstanding. And in the past 40 years or so, from the 1977 till this year, there has been 780 publications all about knowledge, attitudes, and practices about menopause. And in 2021, we have 8 of those already. And to be honest, I mean, we keep on publishing all about those knowledge and attitudes surveys, but they all have common conclusion and results, which is gap in knowledge. And not only that, they all have, a clear evidence that there are deviation from management guidelines. So what do we do? I mean, as clinicians, let's start from the beginning. So again, we wanted to make sure that everybody share the common grounds, particularly for the menopause. So basically, you all know that menopause is a programmed ovarian dysfunction. And it starts from some kind of a trigger, whether it's a genetic factor, environmental or lifestyle, or some systemic diseases that act on the hypothalamus, which leads ultimately to an impaired timing of the LH surge, and then ultimately to the decline in the estrogen production and from the ovary, as well as decrease in ovarian follicular maturation and function. And that happens, as you can see from the figure, directly through the hypothalamus, or indirectly or directly now through the ovarian dysfunction through aging process. So it is a genetically programmed loss of ovarian function, and we cannot state a woman menopausal unless we have at least 12 months of amenorrhea after the final menstrual period, reflecting the ovarian follicular depletion, which usually occurs around the mean age of 51. However, that doesn't happen abruptly. There are like a sort of a prodrome or a perimenopausal period that expands to about 3 years prior to the final menstrual period, where people can see, women can see menstrual cycle variability accompanied by low AMH, low inhibin, and low antral follicular count. And from the time of the last menstrual period, the woman usually experiences vasomotor symptoms or symptoms of urogenital atrophy that will become later in life. And to be honest, I mean, we know that it is genetics, we know that there's an ethnicity and environmental factors, but being a diabetologist, we can't really blindfold ourselves about the impact of diabetes and hyperglycemia, even on the viability of ovarian functions. So women who are known to have type 1 diabetes, their menopause starts earlier at an age of 41 as compared with the non-diabetic sisters, for example. And women with type 2 diabetes can have their menopause even earlier than their non-diabetic counterparts. And there has been some suggestion to conclude that even the higher level of A1C can actually predict an earlier menopausal state in women. It is really important to exclude some of the common scenarios that patients may come with. For example, a woman around the age of 48 may or may not be menopausal, but could be on some pharmaceutical agents like SSRI or some on alcohol, or they're having some anxiety disorders. So we have to make sure that women are not on or having other differential diagnoses for their vasomotor symptoms, for example. And therefore, to diagnose women in the age above the 45 and above, the NICE guidelines, as well as other scientific bodies, they actually do not rely on lab diagnosis for menopause. So generally, we rely on the clinical picture. So women who are healthy women who are having vasomotor symptoms on irregular periods, or probably having more than 12 months of amenorrhea, and with the vasomotor symptoms in the hysterectomized woman. We do not depend on the analysis or the assay of inhibin A or B or estradiol or LH-FSH unless a woman is actually having premature ovarian failure prior to the age of 45. Fine. So these symptoms are quite known to most women and men. And to be honest, I mean, the representation of or the presentation of various symptoms and signs really depends on the perception of the woman and the geographical and the racial background of those women. So this is a nice study that looked at 4 countries and surveyed 300 menopausal women between the ages of 45 to 55. And you can see a variety of presentation of various symptoms of menopause. So we can say that from the left, like Lebanese women, they present with depression. Of course, they have other reasons to be depressed for, but then they have more depression compared to, let's say, American women who present mainly with hot flashes and joint pain. And you can just see through the Moroccan women or Spanish women. So I wish we can just say that we would like to have a quick fix for the problem and having just a quick HRT or some sort of a protein shake that can reverse things out. But it's not that simple, of course. And I just wanted to highlight a few things before I carry on. Women are actually scared, and healthcare providers are scared of HRT because of their impact on cardiovascular system. But please remember that menopause itself can have a detrimental effect on cardiovascular system, which is governed by the estrogen decline. So from the estrogen decline, it is directly or indirectly can cause endothelial dysfunction through activation of some renin-angiotensin system or increase in the endothelin, or indirectly through the increased blood pressure, increased triglycerides, or obesity, and they all pull up to an increased risk of ischemic heart disease if this menopausal thing hasn't been corrected. And therefore, it just makes sense if I can just replace what is missing, then we shouldn't have any cardiovascular issues. But that's just easy to say. But again, it's really important to keep that in mind if you want to discard the issue of HRT. Fine. So my role is now to emphasize on new data that has been published ever since the 2002 Women Health Initiative scared the whole world against HRT. So actually from the Post-Hoc Analysis of Women Health Initiative, cardiovascular disease outcomes published in JAMA were more or less reassuring, and we will see that in a bit. Also, some of the KEEP studies that looked at the cognitive, the menopausal symptoms, and the sexual functions, and how important HRT can be beneficial for those symptoms. The early versus late intervention trial, the ELITE trial, the Swedish trial, and the Danish osteoporosis study, they're all reassuring. And I'll just go through some of the systematic reviews and meta-analysis that were published over the past couple of years. So the focus of newer studies is mainly on women with a shorter history of menopause. They've looked at the different age ranges, the beneficial effects of different formulation of estrogen and progesterone. So to begin with, this is from the Women Health Initiative, the Post-Hoc Analysis, and you can see that they have stratified all the outcomes based on the age ranges between 50 to 59, 60, 69, and 70, 79. And you can see from the p-value here and the relative risk, of cardiovascular outcome, that none of those have a significant detrimental effect on cardiovascular disease, whether patients are on estrogen, progesterone combination, or an estrogen alone. On the contrary, if you see this bit of a sort of a protective effect of HRT in women against MI who received estrogen alone, of course, they are hysterectomized, and they are between the ages of 50 to 59. The same study have also looked at whether women who has a pre-existing metabolic syndrome would be at a higher risk. Well, yes, this is true. So women, as you can see here, that's having an odds ratio of 1.7, if they're having, for the risk of developing heart disease, if they're having a pre-existing metabolic syndrome. So that's in a way reassuring for women who are just don't have metabolic syndrome and they are younger at age of menopause and they're starting HRT at for a shorter duration. Again, we'll come to that in a bit. Let's look a little bit at the stroke trial. So this is a trial that looked at more than 8,800,000 postmenopausal women in Sweden from the 1987 to 2002. And they were followed up for a mean duration of 14 years. And they've actually looked at the rate of stroke in general or hemorrhagic stroke in women who started the HRT early versus starting HRT late. And they've also looked at different combination of estrogen, progesterone, and different formulation. And the outcome here is not the presence or absence of stroke, but then looking at the years free of stroke to the right-hand side or to the left-hand side of that forest plot. And the conclusion from that study is that early initiation of hormonal therapy between 0 to 5 years after menopause onset, as compared to never use, is associated with a decreased risk of stroke or hemorrhagic stroke, whereas the late initiation was associated with elevated risk of stroke or hemorrhagic stroke when used the conjugated estrogen progesterone as a single therapy. Further studies, which are the systematic review and the meta-analysis just published this year, they've looked at different outcomes and the use of the HRT from various pooled analyses. So definitely, if you look at the genitourinary, vasomotor, and fractures, we have a benefit. But if we look at the cerebrovascular accidents, thrombosis, and cardiovascular diseases, we would have some harm. The same meta-analysis also looked at the risk and benefits, if ever, from HRT for different neoplasms, like the colorectal cancer, we will have some protective effect, but if we have a breast cancer, there's a detrimental effect. They've also looked at the diseases of nervous system, like Alzheimer's. Some studies said it is protective, other studies said that it is harmful. And therefore, it is really important to see the overall picture and look at the population that has been studied. This particular one looked at the breast cancer in a nested case control study in the UK from the 1998 to 2018, and looking at 33,000 breast cancer women versus control, and between the ages of 50 and 78. And they've specifically looked at the recency and duration of use of HRT at different age stratification. And their outcome was that the incidence rate of breast cancer in these women. In general, there has been an increased risk of breast cancer associated with long-term use of estrogen-only therapy. And the odds ratio is marginal, about 1.1. And if they use the combination estrogen-progesterone, then the odds ratio is higher, to closer to 2. And then the combination treatment associated with the lowest risk was really draw the attention to the combination of a safer progesterone combination, estrogen and the progesterone. So the type of progesterone that has been used is also important in the risk of breast cancer. After that, I felt that it's really important after viewing all of those, publications in literature. So what would be the ideal approach for menopausal women? So I thought a woman who had menopause within the previous 5 years from the final menstrual period, we needed to check for the indications and the contraindications to use HRT. And also it would be of benefit to calculate the breast cancer risk and calculate the cardiovascular disease risk. And then we can have the option of having either estrogen or estrogen in combination with progesterone based on the uterus. And of course, we would need definitely to discuss with the patient what is her priority in treatment. Is it for vasomotor? Is it genitourinary, the cognition, or the bone issues? And so let's talk about these things. Basically, it's important to remind ourselves that the main indication of HRT is really to relieve the menopausal symptoms in general. And it can be considered in women below 60 who are having low bone density without the fracture. In terms of contraindications, of course, if we have an active breast cancer or active endometrial cancer or an active CVA, active liver disease, we do not use the HRT. And there's more and more publications advocating HRT in patients with a past history of breast or endometrial cancer, which has proved to be completely free of disease. So those are just relative contraindication and not absolute. The list of precautions expand with time because more people are becoming more aware that maybe those who are having protein C, protein S, antithrombin deficiency would be at a higher risk of thromboembolic disorders, and one wouldn't really initiate HRT for them. Or women who are having diabetes may be at a higher risk of complications based on the metabolic condition for the woman. Moving to the cardiovascular risk, I mean, if you apply the American Heart Association 2013 guidelines, that's a straightforward heart risk calculator. You just enter what is there. Unfortunately, the race is either African American or others. But I mean, with this group of scientists here in this forum, we can still do our own risk calculator. And from that perspective, we can say that if we have a 10-year cardiovascular risk of less than 5%, then, and a shorter duration of menopause, then HRT would be okay. Whereas if we have the cardiovascular risk is more than 10,000, then it is better to avoid hormonal replacement. Likewise, if we do the breast cancer risk assessment tool, we can still categorize the patient as a lower risk or higher risk or even intermediate risk of breast cancer and then work it out accordingly. The vasomotor symptoms, which is the main symptom that brings women to our attention in general, whether they volunteer and come forward to you or they just get referral from their GP. And most of the time, women with vasomotor, they just think that it's probably thyroid. What's really important to make sure this differentiation, and this is not a thyroid. So what happens in the vasomotor symptoms? So there's a sudden episode of intense heat, usually in the face and neck, that is really lasting about 1 to 5 minutes, which is really triggered by an abnormal thermoregulatory zone in the hypothalamus, which is becoming dysfunctional. And that really occurs in about 60 to 80% of women in their menopausal life. And number one treatment for that would probably be a hormonal treatment, what is shown here with the KEEPS trial. You can see that the use of estrogen alone or in combination with progesterone would have a significant improvement in the hot flashes rate, night sweats, and insomnia, but not as much on the irritability rate. If you think about the non-hormonal medications for vasomotor symptoms, we know that a lot of those SSRI medications have been tried, and the one which is FDA approved, which is paroxetine, it can be efficacious in 60% of women. Venlafaxine also has been tried off-label. and also the gabapentin. But you really need to make sure that you really want to put those women on these medications or not. Make sure that the woman is aware of the side effects and whether it will help in other non-vasomotor symptoms of their menopause. Now, lately, which I would really like to share with you, is the identification of the Neurokinan 3 receptor inhibitors. So this actual neuron, which is the caspeptin neurokinin B dynorphin neuron, this is an important neuron in the hypothalamus that has a role in the GnRH pathway as well as in the thermoregulatory pathway of the body. And what happens is that in the case of menopause, where the ovarian estradiol reduces, and to some extent the testicular androgens also reduces, there will be, of course, the negative feedback mechanism to the hypothalamus, and that will upregulate the gene for the caspeptin neurokinin neuron and causes hypertrophy of those cells producing those peptides. And that will lead to, here on the left-hand side, the heat dissipation neuron activation, which will lead indirectly to the sweating and the cutaneous blood vessel dilatation, as well as activation of the muscles under the skin, which would trigger the shivering and the cutaneous blood vessel vasoconstriction. So what happens is that scientists have identified that receptor that will help the binding of those neurons into the heat dissipation cells and block it. So if we can block that pathway and we can block this one, then we wouldn't have the abnormality of the thermoregulatory pathway, mainly in the menopausal state. And this has already been tested in a phase 2 trial and led to the publication in The Lancet in 2017. And it says here the neurokinin 3 receptor antagonism as a novel treatment for menopausal hot flashes. And they've actually tested that in Imperial College London, the Stephen Bloom and Prague group. And they've actually looked at a shorter duration of this medicine in a crossover randomized double-blind placebo-controlled trial. And they've, on a small number of women, roughly around 37 women, randomized into either taking the intervention or a placebo, and then after a period of washout, they have swapped the intervention. And you can see on the right-hand side panel, the significant reduction in the frequency of the hot flushes of more than 80% reduction, which is quite significant in the top panel. And in the bottom panel, they've actually looked whether there is an order effect, whether the patients have started the placebo first or started the active substance first. They have still showed an 80% reduction in the menopausal, the vasomotor symptoms in particular. So to date, there are 3 molecules that are in the pipeline, which I think is, the phase 2 trial has been completed, and then we're just waiting for the completion of phase 3 trial in one from the 3 of those molecules. So that is really interesting, and that will really help our women alleviate their vasomotor symptoms in general. The second most distressing symptom is the urogenital symptoms, which is mainly the vaginal dryness and itching and stress, incontinence, and so forth. And you cannot really get blinded to the actual structural development, structural changes that a woman experiences with the loss of vaginal rugae and elasticity, as well as the change in the vaginal pH because of the reduction in the lactobacillus bacteria in the genital tract, and the change in the pH and the overproduction of other pathogens in the place, creating more UTI and infections. So again, what to do with that? The KEEPS trial showed the beneficial effect of the estrogen, whether used in conjunction with the progesterone or if it is used in transdermal. So that actually looks a bit congested, but you can see that the arousal score, the desire score, the lubrication score, orgasm, everything actually improves with any form of estrogen, except for the fact that the sex hormone binding globulin, of course, the dermatological application of estrogen, the transdermal estrogen, will not have that effect, which is really something really, really good, bypassing the liver effect of the oral estrogen progesterone metabolism. So other non-hormonal therapies for the urogenital syndrome, the use of lubricants and moisturizers, of those, maybe the silicone-based ones would be the ones which are recommended. If we wanted to have the hormonal therapies, that has been actually studied whether the creams, the inserts, the vaginal rings, the use of even testosterone creams and so forth. So in general, there appears to be safe in terms of risk of venous thromboembolism. There's no increase in the risk of cardiovascular diseases, the stroke or PE or MI, and no association with the risk of breast cancer. However, estrogen is estrogen. There should be some sort of absorption, and there would be some contraindication in women with undiagnosed vaginal bleeding or estrogen-dependent neoplasm. Now we come to the main theme of this session, which is bone loss and fragility fracture. To be honest, I mean, it's really important to know the effect of estrogen on the bone health in general. So I'm sure that you would agree with me that estrogen is a main modulator for osteoclasts, osteoblasts, and osteocytes. Then ultimately, there is a reduced bone resorption, maintenance of bone formation, and reduction in activation of bone remodeling. And if we don't have the estrogen, what will happen? So if we don't have that, we will have more of the increased osteoporotic or bone resorption markers, and more of the osteoclast activation will increase the bone resorption and low bone masses and loss of the bone architecture. Of course, this is one part of it, and we do not really focus on menopause and forget that those women are aging. So with aging, we will have the deficiency of vitamin D, the reduced physical activity, and the sarcopenia, and those play together with the deficiency of estrogen in order to promote more of the low bone mass and low trauma fractures. And therefore, if you wanted to talk about the therapies of osteoporosis, I'm sure that you've heard from earlier presenters the role of the different drugs that can be used in postmenopausal osteoporosis. You just need to be aware of what would be the benefit of those, whether I'm targeting vertebral fracture, non-vertebral fracture, or hip fracture, and for how long you would be needing to use those medications for. But if you wanted to talk about the prevention of osteoporosis, then there is the estrogen, whether orally or transdermally, estrogen would be really important category in the prevention of osteoporosis. I'm sure that Dr. Saleh has spoken a lot about the diagnosis and management in postmenopausal women in the Gulf region. And this is something that we are really proud of. And I would advise you that you can have a look at this publication from the group. Now, looking at the HRT, I just want a few things to practical things, like the transdermal is the one which really advocated as an estrogen formulation versus the oral because of the bypass of the liver and the direct effect on the circulation, and doesn't seem to have any major risk of cardiovascular diseases. But if you also wanted to look at the progesterone, it is the micronized progesterone, which is really important to keep in mind that it is minimally adverse effects on the headache, the blood pressure, and the mood. And it doesn't seem to have an increased risk of breast cancer as compared with the main medroxyprogesterone that was used in the Women Health Initiative study. Now, other non-hormonal alternatives for bone, we have the tibolone, which is a synthetic steroid with estrogenic metabolites. And we have the raloxifene. So the tibolone is actually good for the bones with reduction of fracture risk by 50%, but it's actually bad for breast cancer recurrence, as well as bad for the stroke. And it is not FDA approved anyway. Whereas the raloxifene is a selective estrogen receptor modulator. It reduces breast cancer risk, but it's bad for the venothrombotic events, which showed to be increased more than 2.7% with increases of the hot flashes. So it's really important to know what is the priority of the woman. Is it the bone health or is it the vasomotor? And then you can work the options accordingly. A few words about the bioidentical hormones. So those are the identical in molecular structure to endogenous hormones. They're synthesized chemically from yam and from soy, and can be compounded. And some of them are actually FDA approved, but they're not FDA regulated. And the position statement from the American Association of Clinical Endocrinologists have published the common compounded bioidentical hormone preparations, which are readily available in the market. And some women are actually, they prefer that because they think that this is harmless and they're just natural or herbal. And you really need to discuss that with your patient before you can, convince her to be off it. Now, a few words about the bioidentical hormones. And we think that it is a marketing term. It lacks purity, potency, and efficacy, and safety measures haven't been really sustained in all studies. And they are exempted from FDA approval because they fall under the dietary supplement health and education rather than the mainstream medical tests for the drugs. And it is definitely not recommended by majority of the scientific bodies. At the end of the day, I'm going to conclude with where I started. Our role here is to enhance knowledge and practices of healthcare providers as well as our patients. So I would suggest that if you are interested in the topic is to log on to either the British Menopause Society or the North American Menopause Society or the International Menopause Society or the Australian one, or maybe later on we will have some Society of Menopause in the Gulf region. And those societies are really, they vary with the amount of information that they provide free of charge and without subscription. I personally feel comfortable with the British Menopause Society because of the ease and the how easy and comprehensive their material is, and you can actually access it without any issue. This is my final slide. I just wanted to conclude with the latest recommendations from the American Association of Clinical Endocrinologists. It was published in 2017, but they still hold true that the use of menopausal HRT in symptomatic postmenopausal women should be considered. And there all depends on the risk of cardiovascular disease, breast cancer risk, the age and the time of menopause. The transdermal estrogen is less likely to produce any thrombotic or stroke or cardiovascular events. And the progesterone, the micronized progesterone, is the safer alternative. The American Association of Clinical Endocrinologists and other bodies, they do not recommend the use of bioidentical hormones. And it is really worth noting that they are not recommended for the prevention of diabetes. Some of the published data have commented that the risk of developing diabetes with HRT is less, but then this is not really consistent across all studies. And we cannot say that HRT is a preventative tool from diabetes. At the end of the day, the use of HRT should be individualized, taking into account the metabolic, the cardiovascular risk, and age for all those women. Thank you very much for your attention, and I'm happy to take any question. Thank you so much.
Thank you very much, Dr. Huda. That was a very extensive review of a very important topic. I think we have exceeded the time, but I have place for one or two questions. Let me address one of the questions for Dr. Yusuf Saleh. When you decide to stop Rulia, When would you stop it, and how would you take measures to stop it?
What was, sorry for that, what was the question?
Regarding stopping Prolia, when and how? Denosumab.
Right, so denosumab is not recommended to stop it once you start. And the reason is that when you stop denosumab, whenever you stop, if you have a reason, a good reason to stop, the risk of vertebral fractures becomes high, especially in the first 6 months after you stop. So whenever you stop denosumab, you have to give another antiresorptive, usually alendronate or risedronate if you're in a country that uses that medication. The studies with denosumab is up to 10 years and showed progressive increment in densitometry and reduction in both vertebral and non-vertebral fractures, including the hip. So there is the consensus is to once you start, you continue, you don't stop unless you have a very valid reason to stop it, allergies or whatever, something like that, or financial. Otherwise, you carry on with it. If you have to stop it, you have to shift the patient to another medication. You don't stop and keep the patient without treatment because there are several reports and case series of increase in vertebral fractures in the period after you stop denosumab.
There's a question from the attendees regarding the role of vitamin D in type 1 diabetes. It's a big topic. I know maybe you can brief them.
Yeah. We know from observational work that it seems to be important, but we do not have the intensive trial evidence for any impact. So I think the recommendation would be to have the vitamin D, the same recommendations that you do for other children or age-appropriate categories.
Dr. Huda, any role of oxybutyrine, butyrine, in the management of hot flashes?
There are few studies here and there, but the results to be often are not consistent. So we cannot really generalize it, and it's not really present in guidelines so far. So I wouldn't really recommend at this stage.
I would like to thank all of the speakers for those outstanding, informative presentation. And I would like to thank Dr. Nadia for co-chairing this session with me.
Thank you, and all the best for everybody. Thank you.